Approach to ischemic stroke in the pregnant patient. A 30-year-old woman who is 36 weeks pregnant presents to the emergency department 1 hour after she develops aphasia and right-sided weakness. Her blood pressure is elevated at 170/100. The stroke team is called for immediate evaluation. Before any further steps are taken, what are important considerations in the care of pregnant patients with ischemic stroke? Ischemic and hemorrhagic strokes can be devastating complications of pregnancy and the postpartum period, with a threefold higher risk when compared to stroke rates in other young adults. Increases in estrogen levels and clotting factors favoring a prothrombotic state are among many physiologic changes that can predispose patients to cerebrovascular events, while conditions such as preeclampsia, eclampsia, and HELLP syndrome also increase the risk of stroke. In managing ischemic stroke, additional considerations should be given to both maternal and fetal health. For emergent imaging, both non-contrasted CT and MRI are considered safe for pregnant patients. Lead shielding can be used to protect the developing fetus from radiation exposure. While contrast agents are typically avoided during pregnancy, iodinated contrast for CT angiography or CT perfusion may be used if imaging findings would change medical decision-making. Gadolinium contrast for MRI, however, is not recommended for routine stroke care, but may be useful in other neurologic emergencies associated with pregnancy. While pregnant patients were excluded from the major thrombolysis and thrombectomy trials, both treatments should still be offered to patients with disabling symptoms who are otherwise eligible candidates. Alteplase and tenecteplase are classified as pregnancy category C, but do not cross the placenta. Unfortunately, 90% of pregnancy-associated ischemic strokes occur in the peripartum or postpartum periods when the risk of uterine hemorrhage may be considerable, and there is insufficient evidence to recommend thrombolysis in the postpartum period. For severe deficits caused by large vessel occlusions in the presence of salvageable brain tissue, conventional angiography with mechanical thrombectomy should be considered, as there is negligible risk of systemic hemorrhage and fetal radiation exposure can be minimized with proper shielding. As with all treatment options, the risks and benefits of emergent therapy should be thoroughly discussed with the patient and the obstetrics team. Following emergent therapy, pregnant patients should receive standard post-stroke care, including diagnostic workup of other stroke etiologies, blood pressure management, and optimization of vascular risk factors. For secondary prevention, daily use of low-dose aspirin is considered safe. Data are limited regarding the duration of therapy and use of other antiplatelet agents, such as clopidogrel or ticagrelor. Those medications should be considered on a case-by-case basis, especially in the days prior to planned C-section delivery. If anticoagulation is indicated, low molecular weight or unfractionated heparin products are preferred. Warfarin is teratogenic and should be avoided, and there are insufficient data to recommend direct oral anticoagulants which are known to cross the placenta. Finally, while statins are commonly used in secondary stroke prevention, they are contraindicated in pregnant patients due to fetal risks. The same is true for breastfeeding patients or for women who are planning to become pregnant. In summary, pregnancy-associated stroke is a rare but important cause of maternal morbidity and mortality. Acute diagnosis, treatment, and secondary prevention of ischemic stroke in the pregnant patient should take into account the risks and benefits to both maternal and fetal health, involving multidisciplinary care when needed, to minimize harm and to maximize benefits such as functional outcomes. Thrombolysis and thrombectomy in particular should not be withheld from eligible patients. For more information on the management of stroke in pregnancy, please see the course resources.